Slide 1. Welcome MS1 students to part 1 of 2 for the recorded lessons for Peri-Op. Please have your nursing textbook nearby as I refer to examples in your book throughout this presentation. The transcript may not be word for word from the presentation. However, the transcript does capture the essential information from each slide. Please post your questions related to the peri-operative content to the topic discussion board. You will need to view the asynchronous videos of instructional content prior to attending the live class. Additionally, please review the study guide or resources and the optional guided reading worksheet. In our live class, we will discuss questions related to the content and then proceed with an in-class assignment that is worth 2% of your grade. Attendance is mandatory to receive credit. Again, if you have general questions about the material, there is a topic discussion board for your use. Slide 2. Refer to the study guide for the learning objectives. These objectives apply to the entire peri-operative experience. The student learning objectives are what you should be able to do after engaging with the instructional content for this class. Slide 3. Because peri-operative nursing care is found in so many aspects of healthcare, you will find that all these cues and competencies are applicable at some point. Peri-op nursing knowledge is one of the cornerstones of nursing care. Slide 4. Peri-operative nursing concepts. Clinical decision-making is basically the nursing process. Collecting data, noticing clinical cues, making decisions about patient-centered care and setting goals, implementing interventions and evaluating how those interventions affected the patient and if the goal was met or needs to be changed. Since peri-op nursing is present in all healthcare, there are a lot of related concepts. The concepts listed show you how big the topic of peri-op nursing care is. Slide 5. The term peri-operative nursing encompasses 3 distinct phases of surgical nursing. That is your pre-op, intra-op, and post-op. There are nurses that are specialized surgical nurses and nurses who take care of patients before and after surgery and procedures both inpatient and outpatient. It is expected as a nurse in an acute environment that you are competent in taking care of surgical patients. We will discuss each of these phases as we explore the topic of peri-operative nursing. Keeping in mind that peri-operative nursing occurs in all environments of care and over the entire lifespan of patients. Slide 6. The text defines the types of procedures or surgeries on page 1398, and those are listed here for you as well. The reason for surgery may be to reconstruct, diagnose, elective for a better quality of life, such as knee replacement, or could be an emergent or emergency surgery, could be transplant or palliative surgery. Another type of surgery is device implementation, where a G-tube or a cardiac pacemaker is implanted. So vocabulary, you should be familiar with our ectomy, which is the removal of an organ. An example of this would be an appendectomy, removal of the appendix, where ostomy refers to making an incision without organ removal. An example of this would be tracheotomy. the surgeon will make an incision in the neck with the intent to place an airway device. Oscopy indicates that the body part has been viewed or scoped. An example of this would be a colonoscopy. This is where the surgeon uses a camera placed at the end of the scope to view the colon when looking for precancerous or cancerous polyps. A closed procedure requires no incision. An example is a closed reduction of bone fracture. An open procedure would indicate that the body part was opened via a surgical incision. Open procedures often produce large incision sites, increased risks of infections, hypothermia, and longer stays and recovery times. Laparoscopic procedures involve small incision sites. Most likely there will be 3 or more depending on the surgery. These incisions allow the surgeon to insert a surgical instrument into the patient's body to visualize internal body structures by using a tiny video camera that transmits images to a monitor. Other instruments may be inserted to manipulate the organs, explore the site, maybe remove tissue or cauterize blood vessels. Laparoscopic procedures are less invasive than open procedures and usually require a shorter hospital stay and shorter recovery time. Surgical site infections, or SSIs, are reduced, and patients typically experience less blood loss, which is also known as estimated blood loss, or EBL. Surgeons can start a procedure as a laparoscopic procedure and then convert to an open depending on their findings. An example of this may be when performing a laparoscopic hysterectomy. Once in, the surgeon may discover too many adhesions due to performing a laparoscopic hysterectomy. Once in, the surgeon may discover too many adhesions to perhaps endometriosis and must convert to an open reduction or procedure to complete the hysterectomy safely. Slide 7. This is a list of possible members of the OR team. All members of the interdisciplinary team will help care for peri-operative patients. These include physical therapy, wound care, all levels of nurses from ICU to home care, etc. Your book does a great job of identifying the roles of each member of on the interdisciplinary team. Slide 8. Prior to surgery, data needs to be collected and assessed to ensure that the surgery is as safe as possible for the patients. If imbalances in the data are noted, do they need to be corrected prior to performing a surgery or procedure? Do other decisions about the surgery need to be made, such as delaying a surgery? Can you think of how abnormal data could alter a surgery? An example, if your patient is pregnant, the anesthesiologist will need to reevaluate types of anesthesia used. What else can you think of? Decisions to alter a surgery will be based upon the data we collected. Review the diagnostic tests used. Slide 9. Peri-operative nursing is all about the safety of our patients. In the continuous effort to provide safer care to peri-op patients, several groups of evidence-based care or guidelines have been developed. We will talk more about SCIP measures in the next hour. Just so you know, your book does a good job of describing the other terms on the list. Please review these terms and understand them. Look at the National Patient Safety Goals as it relates to surgical patients. You learn about these goals in your pharmacology. These are posted for you in the content page, so take a look at the list as it relates to the surgical patients. Slide 10. Pre-op is all the patient care that happens before the patient is rolled out into the OR. This phase begins when a patient is notified of the need for surgery. It can occur over days, weeks, months, or minutes or hours depending on the situation. For example, someone is having an elective or scheduled hip replacement may know about this procedure for months ahead of time, where someone who needs emergency surgery due to a traumatic event may only have few minutes to hours in the pre-operative phase. Optimally, we want to provide thorough patient teaching and support in this phase. Preparing the patient for surgery is also accomplished in this phase. This may include IV placement, skin prep, maybe an insertion of an indwelling Foley catheter. As nurses, we are assessing our patient, collecting data, and ensuring forms and paperwork must be completed appropriately before sending the patient to the surgery. Slide 11. Nurses provide early patient teaching and reinforce pre-op instructions that are given to the patient. Please look at page 1394 of your book, as it has a nice patient teaching section. We reinforce the information about the nature and anticipated length of the procedure. This will help patients plan and make necessary arrangements. We address whether the patient needs to continue or stop taking medications before the procedure. You may want to think about your anticoagulants, your NSAIDs, maybe your over-the-counter herbal supplements, some certain antidepressants. These can all increase the risk of bleeding for surgical patients. Instruct on how to use the incentive spirometer, maybe coughing or deep breathing, and explain the rationale behind its importance, which is to prevent hypoxemia, atelectasis, and eventually pneumonia from developing. Review the deep breathing steps with your patient. You learn these skills in your skills lab. Provide education about the care of the incision, which is extra important for patients who are outpatient surgical patients. Teach about post-op constipation prevention by encouraging early ambulation, maybe the use of stool softeners or laxatives, encouraging a high fiber once appropriate. You want to discuss pain control and realistic expectations. Identify a pain goal. For example, if their pain is 9 out of 10, a goal could be down to 4 out of 10 by the end of the shift. Surgical patients will experience some discomfort or pain in the process. Talk about interventions that will manage during the post-op phase, such as splinting the surgical site when repositioning. As I said, early ambulation, safe use of opioids, as well as non-opioid pain management options. This would be a good time to discuss mobility limitations too. Also discuss common side effects of opioid use, such as dizziness, drowsiness, nausea, itchiness, and constipation. Remind patients that NSAID use can increase the risk of bleeding and ulcers. Discuss prevention of clot formation with the use of TED-HOS or SCDs, or a pharmacological DVT/PE prophylaxis such as your sub-Q heparin. Early ambulation and bed repositioning will help reduce the risk of clot formation. The clots we worry about are DVTs and PE, which is your pulmonary embolism. We would also educate the patient on skin prep instructions. For example, instructing them to shower with a chlorhexidine solution right before surgery if ordered by the physician. Slide 12. Patients and families require various levels of support. The level of anxiety and need for coping or adaptation interventions will depend upon the type of surgery, the developmental stage of the patient, coping ability of patient and family, and of course, the cultural and religious beliefs. Think about the support that would be needed for a planned procedure versus an emergent or emergency procedure. Think about the procedure type and support required for a curative procedure such as appendectomy versus the first stage of cancer treatment. Think about COVID-19 and visitation rules. As with all nursing care, any plan to provide coping interventions begins with assessment. Slide 13. For planned procedures, we will need to tell the patient when and where to arrive the day of surgery. NPO or nothing by mouth status needs to be reviewed based on the type of surgery. Most surgeons require adult patients to be NPO for 8 hours to procedure. The rationale is to reduce the risk of aspiration. However, there is a new evidence that says this may not be the best practice, so we shall see. Regardless, the nurse will verify NPO status to see if it aligns with the surgeon's recommendations. Patient belongings are removed during the pre-operative preparation phase with valuables sent with security to be locked away or sent home with a family member. During the immediate pre-operative phase is when an additional CHG bath and hair clipping will occur by nursing staff. Additionally, a peripheral IV will be started and an IV fluids and or medications such as antibiotics, antiemetics, and anxiolytics will be administered. Slide 14. Essential pre-operative assessment and data collection includes past medical and surgical history. We are interested in knowing if there were any reactions or complications related to anesthesia. Does the patient have any implants? Is there scar tissue or adhesions from previous surgeries? What type of allergies does the patient have? What comorbidities exist that may affect wound healing, respiratory status, or your circulatory status? NP status, when was their last meal? What have they done or what have they had to eat or drink in the hours before surgery? Does this align with the surgeon's recommendations? What medications are they taking and what medications did they take the day of surgery? What support will they need based upon their coping or adaptation skills? Are there any religious or cultural needs that we need to meet? Please review Table 17.3 on page 1396 for examples of essential preoperative assessment and data collection. Slide 15. Informed consent is a legal requirement for surgery and is completed by the surgeon and the patient. There are allowances for family members to sign if the patient cannot participate, such as critically ill or child, or for an emergent issues like trauma. Anesthesia questionnaire collects data to help the anesthesiologist make safe decisions about medications. Do not lose patient belongings. Belongings needed to be given to a family member or stored away with the security. You should get a receipt for the patient in order to retrieve their belongings later. Slide 16. Intraoperative nursing care occurs within the operating room or 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 procedural room. The intraoperative environment is a high-risk area where there are increased risk of infections, surgical errors, wrong site surgery, retained instruments, burns, and incorrect specimen labeling. The care decisions made in the OR are specific to the patient and the surgery, and safety of the patient and the team is always the most important goal. Constant monitoring of the patient and surgical environment is required to ensure patient safety. The OR team members are specially trained nurses, physicians. The patient positioning allows the surgical team access to the surgical site. You may want to review Table 17.5 for surgical positions and rationals. Padding is used to protect bony prominences and prevent injuries. Failure to position the patient properly can result in patient injury. The nurse needs to consider comorbidities when positioning the patient. Slide 18. In the intra-op phase, there are surgery-specific variables to consider. Surgery types will determine the length of time of the procedure as well as the level of complexity of the procedure. Surgery time and complexity will increase possible complications during the procedure as well as in the recovery phase. For example, a G-tube placement is a relatively simple and straightforward procedure versus a double lung transplant, which is more complex and requires more surgical time. All the equipment needed for the surgery is set up prior to the surgery. All the team members must know how to use all the equipment in order to reduce injury to the patient. The longer the surgery, the higher the risk of complications such as hypothermia, and the more anesthesia medications need to be administered. Again, safety is the top priority. Distractions in the OR are a top contributing factor to increased risk for patient harm. Slide 19. Your textbook table 17.9 lists potential intraoperative complications for you to review. On this slide, we have listed hypohypervolemia, electrolyte imbalances, which would include sodium and potassium, hypohyperthermia, and malignant hyperthermia, which is a life-threatening adverse reaction to the anesthesia medications. Assessment findings for malignant hyperthermia include a superfast high fever. If your patient develops this, treatment must start immediately. Treatment takes at least 3 nurses, a pharmacist, and a couple physicians working fast and hard to provide medication and other interventions to reverse this rare life-threatening reaction to anesthesia. Perfusion and oxygenation problems as well as physical injury, cardiac arrest, and death are other potential complications. In the intraoperative setting, the nurse pays close to possible physiological changes occurring within the patient. We don't assume that another team member is monitoring the patient. In the intra-op phase, the nurse is truly a spokesperson for the patient and patient advocate. The circulating nurse must pay attention to the whole intra-op environment, including changes in the sound of the monitor and urine output. If changes are noticed from the patient's baseline assessment, the whole team is made aware. Communicating this issue supports a better surgical outcome for patients. Slide 20. When we think about patient safety in the intra-op setting, we speak about positioning again. What I want you to understand is that incorrect surgical positioning can lead to injury. The OR team is responsible for promoting safety related to positioning of the patient. Do not memorize what position goes with what surgery. Just recognize that different positions are to promote safety and protect the patient from injury. For example, a patient undergoing cervical spine surgery will have their head secured with pads and screws. I have personally taken care of post-op patients that had notable injuries from the screws not being positioned correctly. As a nurse, it is important to remember that a patient under anesthesia does not feel pain, nor do they have the protective reflexes to reposition themselves to relieve pain or discomfort. So if placed incorrectly, they could awaken with, for example, a nerve damage to an arm. Patients must be positioned appropriately and safely in the OR table for the surgeon to access to the surgical site. This is yours and the team's job to ensure this step is done correctly. We must know comorbidities for patients to reduce risk of injury related to positioning. An example is an elderly diabetic patient. They are at a higher risk for developing pressure ulcers that have delayed healing due to diabetes. So it is important to ensure that the patient's bony prominences are protected. Why does the med-surg nurse who receives the patient from the OR need to think about surgical positioning in their initial patient assessment? One reason is to help prevent clots. Changing the patient's position in bed every 2 hours helps keep blood flowing. This helps the skin stay healthy and prevents bed sores. Turning a patient is good time to check for the skin for redness and sores. Patient positioning is essential to ensure patient safety not only during a surgical procedure, but also before and after. Optimal positioning not only ensures the best possible access to the surgical site, but also prevents long-term consequences such as nerve damage or pressure ulcers. Slide 21. Most surgical patients will require some type of anesthesia. Please review 17.6. The type of anesthesia used will vary and depend on the things such as the type of procedure and the level of the overall health and well-being of the patient. Hypertension and obesity may increase risk of general anesthesia, and therefore conscious sedation may be performed over general anesthesia. Regardless of the type of anesthesia used, the nurse's role is the same. In the pre-op phase, the nurse completes pre-op assessment and confirms informed consent is completed. In the inter-op phase, the nurse assists with the application of monitors and assists with airway management as well as patient positioning. In the post-op phase, the nurse assists in placing the dressing and protecting the patient during the return of protective reflexes such as your swallow, cough, and gag reflex, and also prepares patient to move into the post-anesthesia care unit, or we also call it the PACU. Types of anesthesia include local numb stitches. These do not have to be done in the OR. Sometimes the nurse may not be in the room, but the nurse will assess before and after regional anesthesia that involves medication injected around a big nerve for an entire extremity, such as your hand, your leg, or the foot. The patient is often awake and doesn't have to be in the OR. With conscious sedation, patients should be able to breathe on their own and follow commands. This does not have to be in the OR. Again, examples would be wisdom tooth, colonoscopy, relocation of joint. Continuous monitoring for blood pressure and airways should be performed by the nurse and physician during the procedure and during recovery. Now, for your general anesthesia is when the patient is completely unconscious. This is done in the OR with intubation and the whole surgical team is present. Other medications to maintain homeostasis and comfort may be used, such as medications to keep your heart beating properly, to maintain your blood pressure or replace electrolytes, maybe control for pain and nausea, as well as maintaining sedation. These medications are administered by the anesthesiology and nurse depending on the role and licensure. It is the post-op nurse's responsibility to assess their patient before and after administration of all medications. Blood products may also be required and are always a potential risk for injury to the patient. So all safety rules must be followed. Ideally, the nurse would be aware of the potential for blood loss to be used and will have ensured baseline assessments collected prior to administration. The team must also be aware of religious concerns regarding blood products. For example, Jehovah's Witnesses typically will refuse blood products due to religious beliefs. Slide 22. To reduce surgical site infections or SSI, the patient's skin is prepared with a special cleaning solution such as chlorhexidine, and hair at the site may also be clipped immediately before the procedure begins. You will learn more about this in the next presentation as it relates to SCIP measures. Another safety precaution to avoid surgical site infections is to ensure that sterile field must always remain unbroken. This is your job as a post-op nurse to inform the physician if anyone, including the physician, broke sterile field. Another important safety prevention measure is pre-surgical hand washing. This is not the 30 seconds from your fundamentals lab. The Association of the Operating Room Nurses recommends a 3 to 5 minute surgical hand scrub before donning sterile gloves to reduce the microorganism on the skin of the personnel involved in the procedure. Nurses' role and everyone else, ensuring everyone else is following sterile procedures and all other SSI prevention rules are being followed. Slide 23. In the intra-op setting, documentation by the nurse and other members of the surgical team is being done continuously. This documentation becomes the legal record of care. Surgery start and end times, people and their assigned roles, details of interventions, patient assessment data, which is continually we're reassessing, are all part of this continuous documentation. Informatics helps the team record the data and allows for a clear and concise documentation. The surgical safety checklist is also a document used before anesthesia, before the skin incision, and before the patient leaves the operating room. Times, people, details of interventions, patient assessment, again, continuously reassessing.